this. Heraklion is a nice port city here in Greece. As you can see, a lot of boats. And we have in common because I'm from Rotterdam, and that's also a port city. It looks like this. And our practice is actually somewhere here behind. Can't really quite see it. It's somewhere there, so it's quite close. You see cruise ships and stuff like that. It's also the biggest port city in the world. So this is just a little part of it. And we see a lot of patients that work in these kind of environments, so you can imagine they have all kinds of problems. And SI joint problems, those are very, very common. Our grandfather, Dr. Hackett, also spoke about them a lot in his books. And well, has anybody here in the room has any SI joint problems? I've had it, and sometimes still have, because I'm tall and I sit in the car wrong and stuff like that. So we are very susceptible to this. So let's start off with a little bit more detailed picture here. So these are the pictures that Dr. Hackett made for us. And we start off with the iliolumbar ligament and the ABCD point, obviously. And we can see where the pain can go. So it can be local pain, obviously, because we see when we see in an advertisement or something, when people have back pain, they always do like this. They always point to the lower back. It's usually the SI joint, iliolumbar ligament. But it can also radiate out to the groin area, to the leg, and give these pseudoradicular pains. So these referred pain diaphragm gives an indication where the pain goes, but doesn't really give an etiology. Why is the pain there? Why are these ligaments irritated, painful, injured, or inflamed, or what's going on there? So let's dive a little bit further in two things. So as chiropractors, you know, my parents are both our parents, because I'm here with my sister, our parents are both chiropractors, so I've seen this my whole life. I went to conference since I was 13 or 14 or something like that, so I've seen these kind of charts many, many times. So we know the SI joint can move, and it can be quite complex, you know. It can give you nutation and counter nutation, and there's all kinds of forces that are at play. And at times this kind of thinking and this kind of stuff can be quite complex, especially if we need to apply it to our patient. So somebody comes in and we need to diagnose their problems. I don't have the time, or I don't have the how do you say that, the will to write point with these forces and measure them out and this stuff like this. This is quite complex. Luckily, there is a doctor who's thought about it and then really simplified this for us. And that's this guy. So this doctor is also from Canada. It's Dr. Wolf Schamberger, and he wrote this book, The Malalignment Syndrome. And this is really one of the best books in this kind of area. And I know one other doctor in this room, not yet in this room, but he is also a big fan of this book. So maybe during this year you can read it in English, or maybe even in Korean. So we will see. So I need to explain a very simple thing about the biomechanics. So we're going to touch on this phenomenon right here, because as a chiropractor, we see a patient and we diagnose what's usually a hypomobility. So as we know, the SI joint can move a little bit, and it doesn't go straight forward, but it does so in a V shape. Yeah, so the both ilia, they move in a V shape. And one of the most common malalignments, or hypomobilities, or how do you want to call it, is this combination. So one ilium goes to posterior and inferior like this, and the other one goes to anterior, and this kind of gives a twist in the pelvis. Yeah? So with this twist, what happens? All the ligaments that need to hold it together, they get stretched. You know, in childhood they had this trick called pins and needles. We grab somebody's arm, we do this, right? And it's quite painful on the skin. It's exactly the same what happens with these ligaments. And we know there's a lot of mechanoreceptors, proprioceptors, so this triggers a lot of muscle reflex. What also happens is on the posterior rotated side, usually we see an elevated leg. And I'll come back to that later, why that is very important that we check this. So the constellation is quite common. It's always going via the 80-20% rule. So the 80% of the time this checks out, and 20% of the time there's a variation. It's a little bit different, but because it's never 100%. Okay, so this is a picture or a poster we have in our practice. So this is how we try to visualize our patient. Somebody comes in with pelvic pain, with this syndrome, so the malalignment syndrome. We see a raised hip, but what this gives is it gives muscle tension locally, obviously. Hip muscles contract, which in turn pull on the greater trochanter, which in turn can get ugly there. These back muscles, they start to contract more, they pull on the thoracolumbar fascia towards the trapezius, towards the neck muscles, but also goes down to the hamstring and to the calf muscles. And this is usually on one side, this muscle tension. So whenever I have something, strange enough, it's always on my left side. And maybe you have other patients, they say, oh yeah, my knee hurts on the right side, my hip hurts, and my shoulder and my neck, why is everything on one side? So that might be because of this syndrome. So when we reason out of the SI joint, this can give all kinds of trouble. So what we see a lot is people like soccer players who have hamstring injuries. It's very, very often because of hypomobility in the SI joint, so a stuck SI joint. Achilles problems, foot problems, anything. So the patients that come into our practice, no matter if they come for neck pain or pain for plantar fasciitis, we always try to check for this syndrome, is this underlying? So this is a beautiful picture. I love this picture. It's incredible how the body made all these ligaments in my eyes. So I love looking at this. But so these ligaments, they start to get stretched if there's what chiropractors call a subluxation. So there's a torsion in the pelvis. So that in turn gives muscle tension, and that in my eyes can also irritate these nerves. So the superficial cutaneous nerve. So I know some of you here have done the neuroprolotherapy workshop in Athens earlier this week. So when I see these graphs, I always think, yeah, well, why are these nerves irritated? Why is it then only on the right side or left side and one not the other one? So maybe there's a mechanical explanation of it, because of the muscle tension that gives a higher friction on these nerves, and then you have a nerve problem. And you can treat these nerves, but if you don't look at the mechanical thing under this, yeah, then it's destined to come back. Same with what we also see a lot is groin problems in soccer players and other sports people. 9 times out of 10, they also have a problem with the SI joint. And this might have been recent, and it might have been because of posture, or because of they do a sliding and it slides out or something, but it might be also something chronic. So this is a first step why I use neuroprolotherapy, for instance, and chiropractic treatment always in conjunction with each other, because they amplify it. One is more mechanical, and the other we give a sort of chemical treatment, as you like to say. So that's that. All right, so what is a very easy way and a quite reliable way to, and once again, it's always the 80-20% rule. How do we check for the malalignment syndrome? So we have this poster, and if we reason out of the SI joint, we can of course check the SI joint itself. It's called joint play. So you kind of try to feel if one side moves properly. If the patient is in the prone position, you just gently press it, and the other one feels stuck. And the patient usually also feels this. But another way is this, with a leg length difference. Yeah. So we put them on the chiropractic table. It goes down like this. They're in the prone position, so on their belly, and they start out like this. So we see here, obviously, a shorter leg. And when we don't manipulate this, we just let them lay down in their natural position as they feel comfortable. And usually we always ask, well, are you in the straight line now? And they say, yeah, sure, I'm in the straight line. And then we put them in the straight line, and they say, oh, this feels weird. So they start off like this. So you see sometimes quite dramatic leg length difference. And then you can say, yeah, but is this not anatomical? Yeah, maybe. But this happens if we only just correct the SI joint. This is what happens when we correct the SI joint. This is what happens when we only do the SI joint. Only that. No muscle work, no nothing. So this is only the mechanical adjustment. Of course, is this solely because of a rotation in the SI joint? No, because the muscles also pull on it and they pull the leg up. So there's more muscle tension on this side, but apparently it releases quite quickly, or it changes in some way that you immediately after just one manipulation, you can see this kind of difference. So if you see this in the patient, a lot of doctors rush to put a heel lift under this. They say, oh my God, look at this, we need to put a big fat heel lift on this. But then it's even again, but basically you're just only making it worse. All right, so how do we treat this? So this is called the Thompson Technique. So this is what we love to do in our practice. I've grown up with this. My dad, I won't tell you the anecdote, but he started off with this in the 80s. He loved these tables, and I have a little movie, if it works. I hope so.
I don't know.
Now there we go. And so this is a practical demonstration. So this is one of our patients here. Ben je the recorder? Okay. Right, guys. So this is my patient Dennis from Holland, and we're going to demonstrate how to look for the leg length discrepancy. So we have this table here. Okay, dan mag je eventjes komen staan. Okay, so kom maar dichterbij dat je het goed kan zien. So this guy has been a patient for us with us for many years, and what we always check in this case is the leg length difference. So the table goes down automatically, and now we look for the leg length discrepancy. And what do we see if we just put the legs right beside each other? We see the right side's been pulled up. We see that very clearly, and I'm not just doing it for the movie or something. This is real life. So usually this indicates it as an SI joint problem, and certainly in this case we know it usually is SI joint on the right, which we then correct with this maneuver. So the ilium is posterior, which gives muscle tension and pulls up the muscle. Basically lifts up the acetabulum, that's one part of it, and a lot of muscle tension pulls up the leg. So that was part one. Let's see what that has done. Well, it's almost perfect. You already see the difference. Just needs a little bit more. And we do it like this. Okay, one. We lift up the leg, which causes it to want to move forward. And we just basically do a drop manipulation. It's called the Thompson Technique. And then again, we see the legs are corrected. Thank you very much. So you see, this is so easy. So with this technique, it's called the drop technique. And what I love about this, if people have ligament issues, then this is a very neutral way of correcting the bones. So in a lot of other chiropractic techniques, like the next one, wait a second, like this one is called the side posture, and everybody knows this, and it cracks, and they usually put nice looking ladies on the table and they film it, you know, because, I don't know, for the views, I guess. But this is how you create lifelong patients. This is great for your business, but not so much for the patient, because this is how you stretch out these ligaments more and more. And if a hypomobility has a hypermobility as a cause, as we will come to later, you're only just basically treading water all day, you know, trying to keep your head above the water, but you never really heal it. So I would not advise this. Of course, with regular patient who come in, they say, oh well, if I have like twice a year I have a bit of pain, and if you do this then it's fine again, sure. But if you have like women with problems after pregnancy, or people with recurring things, I would not advise this manipulation. Also the Thompson technique, so this correction is also safe with people with herniated discs. And I would not like to have too much rotation on people with herniated discs, either with or without symptoms. Because we have seen also, of course, in our practice that people without radicular pain or that have healed, and then we've done this manipulation, it was maybe a little bit too harsh, then they say, oh well, a few days, you know, I kind of had this tinkling back in my foot, and so we try to shy away. We really try to shy away from that. All right, so but how does prolotherapy come in? If this is such a great treatment, why do we need prolotherapy? All right, so I already explained a little bit. So what happens if we correct this and we take away the, wait a second here. If we take away the pressure from the ligaments, so the malalignment, you take away the pressure and normally the ligament would heal. Yeah, okay. But sometimes these ligaments can't really heal anymore because they've been stretched out so often, or there's something else wrong with it. So the manipulation, so the malalignment returns very quickly. So these are usually the patients. They say, "All right, thank you, you corrected me. I went back into the car, and then oh, I felt my SI joint plop out again." Yeah, they come back in, and we adjust them, and then we send them out again, and then the next day they call, "Yeah, you know, I was in bed and I was doing this, and poop, I felt it go out again." So then we say, "Yeah, hello, this is not okay." So then we're going towards the instability. So basically, if you do a correction and it doesn't want to hold, then it's usually a great indication for prolotherapy. So then we're looking at the hypermobile lesion, not so much a hypomobile lesion, but a hypermobile lesion. And this can also, as a result, be the cause of the hypomobility. Do you understand? Because of the hyperlaxity of the ligaments, the ilium goes out too far and then it gets stuck. It doesn't want to go back. Another way of checking for hypermobility, obviously, is the active straight leg raise test. We know this one because it's a great test for the load transfer over the SI joint. And the other one, there are many tests, but another one, if you combine these two, the specificity and the sensitivity go up, is the posterior pelvic pain provocation test, which basically, if you give axial pressure down and then people feel pain, recognizable pain in the SI joint, and then you have to treat these kind of things. So I think I don't have to go over all the lumbar A, B, C, D points in this presentation. I might not have time for it. But once again, people with these kind of problems can have this. All right, well, thank you very much. A few take-home messages. Check for malalignment, hypo versus hypermobility. Adjust, don't just heel lift out of the blue. Help the ligaments heal, and then you can cure most of your patients. Well, this is actually a team, so thank you very much for this presentation. Thank you.
Actually, you can have the,
Oh, yes, of course.
Excellent presentation. If you don't know this, chiropractors are the ones that readjust. The patient gets back, like he was saying, and they get. So for prolotherapy, this is it. We can tighten those ligaments up, fix them up. But if you have some knowledge of manipulation, or you want to learn basic, there are easy things. This is just going to improve your prolotherapy treatment.
Exactly.
Excellent lecture. I like that. I have a question for you, then I'm going to pass the questions on today.
Okay.
We're living in a right-handed world.
Yes.
Besides London, England, they're in the left-handed world. Okay. Or the Bermudas or so on. Do you find that the right side of the body is more involved?
I think
right side short leg. I see a lot of right side short legs more than left side.
Yeah, I guess that's a possibility. I do know that left-handed people in the right-handed world are more protected, but I don't have the statistic just off the top of my head, to be honest. But it's usually on one of the other side. In my case, it's always on the left side.
Really? Okay.
Yeah. So I'm a bit special, you know, of course.
One of the top chiropractors that is not with us anymore, Dr. Bryson, he always mentioned that the right side was more involved than the left side.
Okay.
And actually, I was looking at your photos, and it looked like they were more
exactly.
right-sided.
Yeah.
Okay.
Guys, exactly. Yes.
You could ask questions while I set up my presentation. Go ahead. Please ask questions. If not, Adrian, you take it.
Yeah, I have a question.
Yes.
I want to make just to better to check if I understand.
Yes.
So you talk about the right side, you have a short leg.
Short leg. Yes.
Posterior hip, much more tension in the hip. So you make this manipulation by mechanical treatment.
Yes.
You have an anterior adjustment.
Exactly. Yes.
And then for make it stable, for make the result stable, you start with prolotherapy.
Exactly. Yeah.
You wanna make it more stable, but
yes.
For how long?
Well, so what we do if we correct it, and the pelvis and every other area in the spine is in good alignment, Then what I do is I treat both left and right side of the SI joint to really strengthen those ligaments of the iliolumbar ligaments, sacroiliac ligaments, the inferior ligaments, and it's like a sling. It's like a U. So the iliolumbar goes down, and then SI joint up, and the other iliolumbar. So I view this as like a U form, U shape, and this needs to stabilize it. So what my goal is with my patients is that it stays forever. Forever, of course, yeah. It's never forever because, yeah. Yeah, so that's the beauty. That's the beauty. If we can correct them and meanwhile also work on the strength of the ligaments, then the end result is usually very good. Yeah. It depends, you know. I think maybe of all the chiropractic patients that come in the first time, I think maybe 70–80% are happy with chiropractic. They get released, the body heals the ligaments, and they say, okay, I'm good, you know. No, it's usually a couple, like 3–4 times. Like the gentleman I showed you in the video, he's got very physical work. So he makes like these sail sheets for sailboats, right? So he's on his knees and working like this all the time, and he's twisting and turning because he has to cut and do, and so he has a very high re-injury rate because of his profession. And other truck drivers, stuff like that, or people that have to carry heavy loads and move around like this. So I won't say it's forever, but you do structurally see that they need you less and less and less and less. Maybe this guy comes in every 2–3 months or something like that. So, and in the beginning it was like once every week because he was in so much pain. Yes, sir.
When the person comes in with a lot of pain, is there a prolotherapy to help the pain generators?
Yeah, exactly, yeah. So if somebody comes in like this, there's no way they want to get on this table. There's no way they want to get corrected. Sometimes they do, but the pain never goes away. So in that case, we start off with injection therapy. So just to calm down the area a little bit, and then when they're back in calm water, we can start at the structural process of correcting. Yeah. Yes, sir.
Do you have a particular rhythm that you use as far as prolo and chiropractic? You work with some chiropractors that
Yes.
do prolo and,
Yeah.
and have them reassess every week to make sure the alignment's staying.
Yes.
And re-prolo 4 weeks later.
Yeah. Yeah, it's something like that. So it's also quite individual. At every treatment, if I see the patient every few weeks, 3–4 weeks for prolotherapy, I always check this. And if I say, oh, well, it's okay enough, good enough, I just do prolotherapy. Or when I see, oh, this needs to get corrected again, because the correction is not so, if you leave the correction alone and you don't correct it at all and use the prolotherapy, it's not that it grows and it hardens in the wrong position or something. You can always correct it afterwards. It's much easier to get something hypomobile a little bit more mobile than something that is hypermobile a little bit less mobile, you know. So that's very easy.
I'm going to add to that. That's a good point that you brought up.
Yes.